is Safe Anesthesia Practices in Pediatrics. And to conduct this session, I would like to call upon stage Dr. Zahid Selot as the moderator of this session.
Bismillahir Rahmanir Rahim. As you all know, that we are holding the 42nd conference of Pakistan Society of Anesthesiologists, and the theme is Safe Anesthesia Practices in Varied Health Facilities. We now commence today's specific session on the safe anesthesia practice in pediatric population. May I request our chairs to please come on the dais. The first on the is Professor Fawzia Anis Khan, who is a well-known to the fraternity of anesthesiology both nationally and internationally. Professor Khan is associated with Aga Khan University Hospital, Karachi for many decades. She had been in the chair of the department from 2002 till 2010. She has more than 170 articles in peer-reviewed published journals. Dr. Professor Fawzia Anis Khan, please. Now, my next chairperson, the dignitary, is Professor Shahida Khwaja. She is also the Chief Executive of the National Hospital and Postgraduate Medical Center, Lahore. She is also the chairperson of Call Associates Group of Anesthesia and also the past president of Pakistan Society of Anesthesiologists Center. Professor Shahida Khwaja. Now I request Professor Fawzia to please call the first speaker of this session. Ma'am, please.
Assalamu alaikum, everyone. The first speaker of our session is Professor Shahab Naqvi. He is Head of Department Anesthesiology and Intensive Care, CEO Behria International Hospital, Rawalpindi. He is going to talk to us about preoperative fasting, ASA Guidelines 2023. Professor Shahab.
Thank you, ma'am. May I start, please? Thank you. First of all, thanks to the PSA Karachi chapter organization for giving me this great opportunity to be here this morning. I didn't know that this session is specifically for the pediatrics, but my talk is about the journal generally. So it is about 2023 guideline updates of 27 ASA guidelines. So we all know what जो बहुत दिन से लोग practice कर रहे हैं anesthesia, we all know what it is, but there are certain few very subtle changes that they have made. But before we start, may I request the people who are sitting at the back to come over. You know, the hall is just empty and you are sitting on the back. Are the youngsters, the younger anesthesiologists? अच्छा, कितने लोग ऐसे हैं हमारे हॉल में इस वक्त जो ये समझते हैं कि जो अपने मरीज़ को ये कहते हैं कि कल आपका ऑपरेशन है और 10 बजे के बाद कुछ खाना पीना नहीं है? Adults and peds. Not peds, generally adults. कितने लोग ऐसे हैं जो ये कहते हैं कि 10 बजे के बाद खाना पीना नहीं है, सुबह ऑपरेशन है? ईमानदारी से सभी कहते हैं. आई हैव नेवर सीन ए पर्सन जिस मरीज को ये हिदायत ना मिली हो कि कल आपको ऑपरेशन है. हाँ, कुछ लोग मिडनाइट पे आ जाते हैं, कुछ कहते हैं 10 बजे आप खाना खा लेते हैं तो बस ठीक है, 10 बजे इज़ गुड टाइम, 12 बजे तक आप सो जाएं दवाइयाँ लेके, एंड तो कल आपको ऑपरेशन होगा. एंड मोस्ट ऑफ द टाइम दिस इज नॉट द फर्स्ट केस टू बी डन. यू नो, मैनी टाइम्स इट हैपन्स कि वो डिले होते होते अगले दिन 12 ही बज जाते हैं कभी कभी. तो ये अक्सर बड़े हॉस्पिटल्स में ये सारा कुछ होता है. एंड दिस इज what happens with the patient. कि जब हम मरीज को ये कह देते हैं तो उसका मतलब ये है कि हम उसे कहते हैं कि आप सारा दिन बैठ के खाने के बारे में सोचते रहें और शायद अपनी बीमारी जो है वो थोड़ी उसकी स्ट्रेस शायद कम हो जाएगी और खाने की स्ट्रेस बढ़ जाएगी या whatever. So question is, why do we tell them to go NPO? We all know the reason. Though it is very rare gastric aspiration, especially in expert hands, 1 in 10,000 in adults and 1.3 in 10,000 in children reported. But in 2021, ASA claims analysis of aspiration of gastric content events, 57% of aspiration incidents resulted in death. So, and another 15% resulted in permanent severe injury. So it is a very severe problem, very serious problem. So that is why we are so concerned about this NPO. और कुछ लोग थोड़ा सा ओवर केयरफुल होने के लिए, और क्योंकि हमारे मरीज़ भी इतने कंप्लाइंट नहीं होते, तो जनरली उन्हें ये इंस्ट्रक्शंस दी जाती हैं कि आपने इसके बाद कुछ खाना पीना नहीं. So next is it really absolutely benign to tell them to go NPO? Effects of overnight fasting could be, just they increase the threat of, in addition to the threat of, hunger and वो जो food dreaming वाला concept है, उसके अलावा hunger, thirst, dehydration, anxiety, all is there, tiredness, enhancement of the gluconeogenesis as well as insulin resistance, unstable hemodynamics and potentially harmful influence of cardiac preload. बहुत सारे पेशेंट्स हैं वो हाइपोटेंसिव हो रहे होते हैं, फिर शुरू में जैसे ही हम उनको जीए देते हैं तो वो हाइपोटेंसिव हो जाते हैं क्योंकि वो हाइपोवोलेमिक भी हुए होते हैं. तो increased catabolic response to surgery is also noted. The next is that the NPO exclude or reduces the risk of aspiration. There are several studies, but I quote just one. और उसमें आप एस्पिरेशन ले लें, डिसैचुरेशन इवेंट्स ले लें, नमोनिया ले लें, इन सारे केसेस में पी वैल्यूज़ अगर आप देखें इनकी स्टडी की, जो खासी बड़ी स्टडी है उसमें 0.6, 0.7, 0.7 ही है. That means there is no significant difference between the two groups. But of course, we have to keep this thing in mind that there are certain conditions in which gastric emptying time is more than normal. Multi-system trauma है, for example, head injury, burns, sepsis, shock, और very fatty meal अगर उन्होंने पहले लिया हो, especially in pregnancy, second and third trimesters में अच्छा खासा यानी टाइम बढ़ जाता है. 99 minutes से it increases to 137 minutes in the third trimester. So that is also, a matter of concern. Risk of aspiration is also increased, especially in the cases. तो जो गाइडलाइंस है उसने हेल्दी इंडिविजुअल्स का जहाँ नाम यूज़ किया है उसमें उनका मतलब ये है कि वो लोग हैं हेल्दी इंडिविजुअल्स जिनके लिए गाइडलाइन उन्होंने 2023 अपडेट दी है, जिसमें कोई अनकंट्रोल्ड गैस्ट्रो इसोफेजियल रिफ्लक्स डिजीज़ नहीं है, जिसमें हाइटल हर्निया नहीं है शामिल, ज़ेंकस डायवर्टिकुलम शामिल नहीं है, एक्लेजिया, स्ट्रक्चर, प्रीवियस गैस्ट्रिक सर्जरी, गैस्ट्रिक बाईपास जैसे होता है, गैस्ट्रोपेरेसिस, डायबिटिक नहीं है, ओपियाइड यूज़ नहीं है, जीआई ऑब्स्ट्रक्शन नहीं है, ओबेसिटी नहीं है, एमरजेंसी प्रोसीजर्स नहीं है. तो जो गाइडलाइंस जो डिज़ाइन हुई हैं उनमें ये चीज़ें जो है हेल्दी इंडिविजुअल्स की डेफिनेशन से बाहर हैं. जब वो कहते हैं हेल्दी इंडिविजुअल्स, सो दीज आर नॉट द हेल्दी. सो इट इज़ जस्ट गोइंग थ्रू द गाइडलाइंस. ASA ने 2002 में जब गाइडलाइंस बनाई थी तो उन्होंने कहा था कि मॉडरेट सेडेशन हो, डीप सेडेशन हो, सारे केसेस में फास्टिंग वाज रिकमेंडेड. ग्रेजुअली जो है वो थोड़ा सा लीनियर वो होता गया और 2017 की उनकी गाइडलाइंस थी और उस पर अब अपडेट दिए उन्होंने 2023 गाइडलाइन में जो उनकी टास्क फोर्स है उसमें मेनली उन्होंने 4 इश्यूज़ जो हैं उनको टारगेट किया है. These are carbohydrate containing clear liquids, simple or complex, देने चाहिए, कब तक देने चाहिए, और प्रोटीन कंटेनिंग क्लियर लिक्विड्स वो दे सकते हैं या नहीं। च्यूइंग गम के ऊपर उन्होंने किया है, और क्लियर लिक्विड्स फास्टिंग ड्यूरेशन 1 आवर वर्सेस 2 आवर फॉर चिल्ड्रन। तो ये 4 टॉपिक बेसिकली उन्होंने इस अपडेट में कंसिडर किए हैं। एंड दिस इज़ दी स्ट्रेंथ ऑफ एविडेंस। जैसे उन्होंने हाई, मॉडरेट, लो, वेरी लो इंसिडेंसेस किए हैं, तो वो आगे थोड़ा सा हम और उसको एक्सप्लेन कर सकेंगे। इसमें आई डोंट नो वेदर इट इज़ रीडेबल और नॉट, बट दिस जस्ट सेज दैट कार्बोहाइड्रेट कंटेनिंग क्लियर लिक्विड वर्सेस फास्टिंग के जो उन्होंने रेंडमाइज कंट्रोल ट्रायल्स, आप देखेंगे कि ये फर्स्ट लाइन में दे आर रेंडमाइज कंट्रोल ट्रायल्स सारे जो है, और दूसरे में पेशेंट्स और नंबर ऑफ पेशेंट्स हैं जो 2000 3000 तक भी हैं कुछ ट्रायल्स में। इसमें क्रॉसओवर स्टडीज़ भी हैं, और इफ़ेक्ट उन्होंने ढूंढा है कि इसमें यानी इनहेलेशन की क्या रिस्क है अगेंस्ट फास्टिंग अगर करें क्लियर लिक्विड्स के साथ ग्रुप्स को कंपेयर, तो एस्पिरेशन का कितना रिस्क है, गैस्ट्रिक वॉल्यूम कितना है, और थर्स्ट और कंफर्ट लेवल्स ऑफ द पेशेंट्स। तो उन सब में उन्होंने यही कहा कि जो पेशेंट्स कार्बोहाइड्रेट कंटेनिंग क्लियर फ्लूइड्स ले रहे हैं वर्सेस फास्टिंग, दे फील मोर एनर्जेटिक and more thrust is less, hunger is less, और दूसरा ये कि respiration और उसका जो है risk is minimal, is there is no difference between the two groups. फिर there is a comparison between carbohydrate containing clear liquids versus non-caloric clear liquids. इसमें again there are more than 20 randomized control trials, crossover studies भी हैं, और आउटकम्स में उन्होंने लोअर पेशेंट रेटेड हंगर है, लेस थ्रस्ट है, लोअर पेशेंट रेटेड थ्रस्ट है। तो इन सब में भी इफ़ेक्ट्स ऑलमोस्ट जो है नॉन कैलोरिक फ्लूइड और फ्लूइड्स कंटेनिंग क्लियरली कार्बोहाइड्रेट्स, फॉर एग्जांपल जैसे कि ग्लूकोज आप मिक्स कर लें पानी में, या फ्रूट जूसेस विदाउट पल्प that are included, ORS is also one of them, या complex carbohydrates में maltodextrin as carbohydrate loading intervention। तो उनको जब कंपेयर किया उन्होंने नॉन कैलोरिक क्लियर फ्लूइड से, फॉर एग्जांपल कॉफ़ी का उन्हें कप दे दें, या ब्लैक टी दे दें, या ब्लैक कॉफ़ी दे दें, या वाटर दे दें, तो उन सब से जब कंपेयर किया है तो थ्रस्ट लेवल्स में तो इतना फ़र्क नहीं है, लेकिन हंगर लेवल में और उसमें दे आर बेटर, द पीपल हु आर कंटेनिंग कार्बोहाइड्रेट containing fluids. Protein containing clear fluids, all protein containing clear fluids contain the carbohydrates as well, and when they were compared, though evidence strength of evidence is very very low, और जितने भी ग्रुप्स थे उन सब में यानी कि one of the group contained about 629 patients। तो इन सब ग्रुप्स में प्रोटीन कंटेनिंग कार्बोहाइड्रेट fluids में, although there was no difference between the two groups generally, but the consensus was that this should not be encouraged before the surgery. Non-caloric clear fluids से उन्होंने कंपेयर किया, थ्रस्ट लेवल्स दोनों में एक जितना कम हुआ, और थोड़ा सा हंगर का जो लेवल था वो इसमें प्रोटीन कंटेनिंग क्लियर फ्लूइड्स में बेहतर था। Especially इसमें though there was no difference between the two groups, but the evidence strength was very very low, so they have not a clear cut recommendation के protein containing fluids उनको देने चाहिए या नहीं देने चाहिए। Now coming to chewing gum versus fasting, there are certain people who like to chew the gums all the time। तो उसमें इनिशियली देयर वाज नो सच रिकमेंडेशन कि उनको अलाउ करें या नहीं करें। पीपल यूज्ड टू टेल देम कि दे शुड नॉट डू इट बिकॉज देयर आर सम स्टडीज दैट शो दैट द गैस्ट्रिक वॉल्यूम इज इंक्रीज्ड व्हेन यू च्यू गम्स फॉर अ लॉन्गर टाइम। बट नाउ आफ्टर दिस स्टडी उन्होंने जब गैस्ट्रिक वॉल्यूम ऑब्जर्वेटरी मेथड से एंड अदर मेथड से जब चेक किया तो दे केम आउट विद द रिकमेंडेशन that although the doctors do not advise about the chewing gums to be taken, but if somebody is taking for their own comfort, they should be allowed to do it. and that can be continued till you give them first sedation. So this is the recommendation. Then it comes to the last one recommendation: 1 hour versus 2 hour clear fluid fasting in children. The clear fluid fasting जो है 1 घंटे से 2 घंटे के दरम्यान में कितना फ़र्क होना चाहिए? In both the cases in children there was no difference, जिसको कहें significant difference between the two groups. जिनको 1 hour fasting कराई clear fluid से, इनको 2 hours fasting कराई. But since the evidence strength of evidence, as you see, is very, very low, so the recommendation came that we try to keep them giving some fluid till as close to the procedure 2 hours before the surgery. So this is the and these are the recommendations, that the healthy adults drink carbohydrate containing clear liquids until 2 hours. Elective procedures requiring general anesthesia, regional anesthesia, or procedural sedation. The carbohydrates may be simple or complex. There is insufficient evidence to recommend protein containing clear fluids preferentially over other clear fluids before elective procedures requiring general anesthesia, regional anesthesia, or procedural sedation. So there is no recommendation. We suggest not delaying elective procedures requiring general anesthesia, regional anesthesia, or procedural sedation in healthy adults who are chewing gum. There is insufficient evidence containing benefits and harms to clear fluids until 1 hour versus 2 hours before regional anesthesia or procedural sedation. So there is no recommendation. To avoid prolonged fasting in children, efforts should be made to allow clear fluids in children at low risk of aspiration, as close to 2 hours before procedure as possible. In children with shorter clear fluid rest, fasting duration, exercise, clinical judgment. So anyways, we have to exercise some clinical judgment. So in brief, अगर हम summarize करें इनको quickly इन 4 recommendations को, तो और ये 20 और बाकी जो ये गाइडलाइन है ये 2017 गाइडलाइंस की सारी एडवाइसेस को अप्रूव करती है. सो रिस्क स्ट्रैटिफिकेशन पहले करें फॉर एनेस्थीसिया रिलेटेड एस्पिरेशन विद द फॉर द पेशेंट्स. For low risk patients, you must have seen that all these studies they have shown before, they were all patients were ASA 1 or 2. Only very small number of patients were ASA 3 patients. So in ASA 1 or 2 patients where there is no extra risk of aspiration, no extra risk of delay in the gastric emptying, so these are the guidelines. 2 hours for clear fluids, 4 hours for breast milk, 6 hours for a light meal or formula, 8 hours for a fatty meal, and for patients who deemed low risk, determine the appropriate length of, who not deemed low risk, determine the appropriate length of pre-procedural fasting by consulting with the anesthesia and surgical team. So chewing gum guidelines do not recommend chewing gums before surgery. However, if somebody is doing it, procedure, even elective procedure should not be stopped, but it must be removed before injecting first sedative. 2 hours for clear fluids, water, fruit juices without pulp, carbonated beverages, black coffee, black tea, etc. 4 hours for the breast milks, 6 hours for light regular meals, infant formulas, non-human milks, 8 hours for heavy and greasy meals. So it is 2, 4, 6, 8 or 1 or 2 in children. So patients who should ingest with small amounts of clear fluids appropriate home medications for acute and chronic conditions regardless of NPO status. So these are the guidelines that they have given to us, mostly the Western populations. Do we really think that these guidelines should be applied to our patients as such? Is there any role that we should develop our own guidelines? Is there any, because we eat different type of food, निहारी पाए और उस तरह की चीज़ें हम खाते हैं, कढ़ाइयाँ खाते हैं शाम को. or we have a different lifestyle, sedentary lifestyle है mostly हमारी population में. Gastric pH फ़र्क है थोड़ी बहुत या नहीं है. I have tried to search the studies, but I couldn't find any study from the Pakistani population. One study from the Indian population was found that said that there is no significant difference between the pHs in their population that they selected as compared to the Western population. But that population was not mostly from the group उन्होंने ख़ास फ्रूट दिए और ख़ास फूड दिया उनको, तकरीबन वही जो लो कैलोरी फूड था. उसके बाद गैस्ट्रिक पीएच चेक किए. सो दैट कुड बी वन थिंग कि अगर हम रैंडमली ये सारी स्टडी कर सकें. और वी हैव a different genetic makeup as well as compared to the our Western colleagues. So in conclusion, NPO after midnight represents a low value and arbitrary practice that leaves patients fasting longer than necessary. Shortening the pre-operative fasting time is one of the focus of the IRAs as well. Early recovery after surgery. Risk stratification for anesthesia related inspiration should be carried out before finalizing NPO time. NPO doesn't guarantee that the risk of aspiration is reduced or absent. Chewing gum, if any, must be removed before giving any sedation. In elective cases, carbohydrate containing clear drinks should be encouraged 2 hours prior to procedure to avoid the risk of hypoglycemia, prolonged stay, anxiety, and the hunger. In emergency cases, rapid sequence induction, we all know, should be available. Provision of head tilting, etc., that should be available. Head injury and these eclasia and gastroparesis increase the aspiration risk. So I conclude in saying that this is the effect of food, generally on the people. So we should not deny them for a very long time. Thank you so much.
I think we'll have the question and answers after the 3 speakers have given their presentation.
Thank you, Dr. Fazia. Now the next speaker is Dr. Farjad Sultan. He's Associate Professor, Chairperson, Anaesthesia's Dow University of Health Sciences, Director, Professional Development Center, Undergraduate Skill Lab, and High Fidelity Simulation Center. His main interest in pain medicine, ultrasound-guided block procedures, and intensive care management. He is going to talk about adverse consequences of prolonged fasting in children. Dr. Farjad.
Thank you very much, ma'am. Assalamu alaikum. Good afternoon, everybody. General Shahab has already spoken about everything. I don't think there's too much left to talk about. But first of all, I would like to thank the organizers for inviting me to give this talk. So when I was given this talk, I was thinking, how should we go around it? And I started a literature search as to what's the whole story behind all of this fasting. So from a historical aspect, the intention behind preoperative fasting was not to diminish the incidence of aspiration, but rather to reduce the unpleasantness of vomiting. And this is back in 1847. So nothing to do with complications, just to avoid, I don't like throwing up. And this carried on till 1883, where Sir Joseph Lister said, no solid food in the stomach, but a cup of tea 2 hours previously is acceptable. That went on and carried on till 1945 during the World War II, after which they actually said, okay, nil paras from midnight onwards, just make life easy. So I'm assuming as the population increased and increased, and anesthesia got better and better, and the surgeons became more adventurous, we had to revise these things. In the 1960s, the pediatricians got a bit concerned, and they said, sweetened liquids for up to 2 hours preoperatively. And that's where it has been. But the thing is that, is this actually a myth that in pediatrics we have prolonged fasting? So if you ask the pediatric surgeons, they say, oh no, it's the same. They don't have prolonged fasting. We do not have this problem. Whereas from anesthetic point of view, when we see the patients and we ask them when they had something to eat or drink. And the numbers we get are quite unbelievable. So just a bit of literature search. Again, these are all out there. So 2011 in the UK, 1350 children coming in, and they measured the median fasting time of 12 hours for solids and nearly 8 hours for liquids. And majority of the children were said, we're feeling extremely hungry or thirsty on admission, not in theater, but on admission. So imagine the delay when they reach theater, so they're getting more hungry and thirsty. In the US, they looked at 219 children, and again, mean fasting time from liquids was 10 hours, for breast milk 8 hours, and for solids, again, 10 hours. Again, same issues. Even then, the pediatric surgeons are saying, it's not a problem. So in Australia, any of the guys sitting here? No. Great. They measured 307 children, and they did an audit and education to improve the situation. The duration of fasting was not reduced by the strategies recommended between the initial and follow-up audit. So if you look at it, the first number they got for clear fluids was 6 hours. After teaching them what is good and bad, it remained 6 hours. For solid was 10 hours, it remained 10 hours. And they were quite surprised with it. They were frustrated with it, that despite teaching them, making an effort of informing all the people concerned of the problems, the problem still remained. And they identified a communication gap. And from the staff saying, and including the parents or caregivers saying, to be on the safe side. So safe side of what? So avoidance of aspiration. So the Mendelssohn syndrome was identified and published in 1946, and everybody takes that on board. But that was for obstetric patients. Does it actually apply to adult non-pregnant population or pediatrics at all? Or we just haven't bothered thinking too much. We just taken something, seen the evidence and saying, yes, this is it. Whereas we all know that the physiology in the pregnant population is quite different, the gastric physiology and the GIT physiology. The avoidance of aspiration was given to the increased risk of regurgitation in the pediatric population. Maybe they had a loss of low airway protective reflexes. If you give them too much, they may not be able to cough it out. They may not be able to protect their reflexes, specifically in a patient coming in who's maybe a bit sick or a bit unwell, and they have increased gastric volume due to whatever reason, either a disease process, whatever. And then there's the reduction of surgical risk. The surgeon saying, oh no, if they cough, we won't be able to, they won't heal well. We'll have pulmonary complication. If they cough, they won't have better oxygenation. So these are all the factors they identified over there. So where's the evidence of it? 2015 pediatric anesthesia, they reviewed more than 10,000 children and found pulmonary aspiration. And these are children who were fasting clear fluids till 2 hours before surgery. And they found an aspiration rate of 0.03. So 3 children out of 10,000 actually had a bit of aspiration, which prolonged the stay by 1 day. The average fasting time was 1.7 hours for clear liquids. Then we have and so the question actually arises, should children be fasting at all? Why do we allow them fasting? Maybe we have a change in diet, as Janet Shah was saying, कि पाए और कढ़ाई और ये सब रात को खा कर आते हैं, पूछते हैं कि नाश्ते में क्या क्या है, डॉक्टर साहब अंडा पराठा खिला दिया, ऑपरेशन होने वाला है, an hour before. So that's a separate issue. But general fasting guidelines, should we be teaching them or not? So what are the problems that we have? Well, first of all is the dehydration. Now, in certain parts of the country, specifically Karachi in the summers, it's really hot. It's really humid, and there is a lot of insensible loss. There is electrolyte imbalance, and the patients have a loss of energy. Nidhal pade hue hote hain. बस पड़े हुए होते हैं कि बस हो जाए. So when they're coming in, they're already hypovolemic. They're hungry, they're anxious. In the West, they have said feeling extremely hungry and thirsty. The parents complaining that the child is feeling very cranky. That is a problem. And generally speaking, if the child is fasting, one or both of the parents are fasting as well. Because if they eat, the child will want to eat as well. So not only are you dealing with an anxious, low energy, hungry, anxious and angry child, but the parent on top of it. And Ramzan aa raha hai, so we'll know how we'll be dealing with such patients. Then there's the metabolic stress. Stress hormones are released. And this have a huge impact on the healing and recovery process. And it's not something which will reverse immediately. It's a prolonged process. So once you start on a negative cycle, the cycle goes on and on and on. Then coming to the emotional and psychological impact, the anxiety associated with hunger and thirst, the emotional stress, fear and discomfort, why is the child not allowed to eat? So the children feel things differently. It has been suggested that if they go through this multiple times, they have increased risk of other mental disorders. And the longer the fasting time, the greater the sleep disruption. So it's all a very negative cycle. I won't go through the guidelines, Sir has already gone through it, but generally speaking, 6421 is what is accepted all over. But is it actually followed? I don't think it is. The fasting times for all pediatric population is quite long. So how do we get around it? Well, clear fluids for up to 2 hours before operation, carbohydrate loading with the fluids to maintain hydration and energy level, communication to the parents, the caregivers, and the children as well. For those children who are... Thank you. I wasn't finishing, but near the end, so roll to the finish. So some of the children, if they're old enough, and if you talk to them, they will understand, and you explain to have clear fluids till 2 hours before. We need to talk to them. Education of the staff is very important. So these are all myths that happen. The nursing staff, whether they are guiding the patients correctly and the parents and the patient or the child correctly, or they have their own myths. Documentation, whether we have anything documented, any paper that we can give them which explains this. Then we can go towards adaptive protocols. We assess the patient's need, the fasting and nutritional specific to the individual patient's requirement. That is when we need to get the teams on board as well. So every child should be taken separately. We optimized recovery with the ERAS. I'm not going to go into ERAS, but different pathways and protocols can be formed for major surgery, minor surgery. It just enhances things. It reduces the anxiety, just familiarizing with what is going to happen, how things will happen. And all of this has a positive impact. So in conclusion, we should have an optimal health plan. We maintain the younger patient's health and well-being in the perioperative period. And that starts from when the patient comes into the OPD or pre-op clinic and is scheduled for surgery, or the surgeon decides this patient needs to have an operation. So it's not just our specialty, it's multi-specialty. The care should be child-centered. We should educate the parents, the caregivers, the children themselves, for those who can understand, the staff of what information they are giving. If there is concern, have a pamphlet or something, have a booklet, which should be given to every patient and ensured that they actually understand. And individualized fasting and nutritional needs should be built up as required. Thank you very much. Questions at the end?
Yeah, our last speaker of the session is Dr. Faisal Shamim, who is Associate Professor and Consultant, Department of Anaesthesia at the Aga Khan University. His clinical and academic interests are difficult airway management, ultrasound-guided regional anesthesia and intensive care, and is currently the Director of Regional Anesthesia. Dr. Faisal is going to talk about gastric ultrasound. Does it have a role in the prevention of aspiration?
Thank you, session chairs and my PSC family for giving me this opportunity and honor. I have nothing to declare. So today's roadmap and objectives of this session is, first of all, we would like to review what is gastric ultrasound, how we acquire the images, how we interpret its images, what does it have an implication of qualitative and quantitative assessment of gastric content. The previous two speakers have already shown that the pulmonary aspiration of gastric contents occurs once every 200,000 to 300,000 elective general anesthetics, and we all know that pulmonary aspiration is a fearsome complication. It is somewhat which have a morbidity. It has associated with 20% incidence of in-hospital mortality. And we anesthesiologists, we know that there are several measures to reduce and mitigate the risk of aspiration. And the single most important strategy is to follow the fasting guidelines, appropriate fasting before anesthesia, and the use of prokinetic and antacid drugs. Then we also use rapid sequence induction and intubation. But the problem and variability is there is a significant variability between individuals in gastric emptying time. The fasting intervals are not applicable or reliable in urgent or emergency surgeries. And even when these prescribed time points have been adhered, the stomach may contain either solid or high volume liquid in up to 4.5% of patients. Now, before finding some solution or finding some answers, does it have a role in the prevention of aspiration? I would like to review the point of care gastric ultrasound, which is, it's an emerging diagnostic tool which allows qualification and quantification. Means we can qualify the type of content, and then we can estimate the volume at stomach to see what's the actual volume and how we can interpret into its aspiration risk. So some anatomical concepts. The stomach contains 5 sections, or stomach contains fundus, cardia, body, and pyloric and antrum. And it is the antrum which is the most interested, and we are interested to examine this part of the stomach. So question arises, why antrum? Because it is easily identifiable on ultrasound in the epigastric region. It is the more dependent area, so accurately reflects the content of the stomach. The antral size is the least variable and the one that correlates best with the gastric volume, and it is a hollow viscous with characteristic 5-layered wall. Anahi Perlis is the consultant anesthesiologist in Canada who did a lot of work on point of care gastric ultrasound and published a lot of studies on this topic. She proposes an approach of IAM network to learn the gastric ultrasound, and this IAM framework is the indication, acquisition, interpretation, and medical decision making. So where we can find the best utility of gastric ultrasound? Where there is lack of adherence to fasting instructions like emergency or urgent procedures, or there is miscommunication, or there is unreliable or unclear history like altered sensorium, language barrier, cognitive dysfunction, inconsistent history, or pediatrics, or there is a potential delay in gastric emptying in a subgroup of patients like pregnancy, labor, like patients with diabetes, severe liver or kidney dysfunction, neuromuscular disorders, and critical illness and severe obesity. So for acquiring the images, we use the curvilinear probe in adult patients, and for pediatrics, we use the linear probe, but for pediatrics above 30 kg, it still requires the curvilinear probe. So to acquire the image, we first scan the epigastrium in the supine position, and then patient turned into the right lateral decubitus position. And when we put the probe on the epigastric region, we scan the epigastrium in a sagittal plane, sweep the transducer from the left to the right costal margin, and observe the landmark. And the 5 or 6 things which is must necessary to acquire an appropriate image is the vertebral bodies, long axis of abdominal aorta, the pancreas, the liver, and the short axis of the gastric antrum. So how we interpret these images? So when the stomach is empty, it has no appreciable content in both supine and right lateral decubitus position. It appears flat and collapsed, and this is typically called a bull's eye pattern. So when we drink fluid, it distends the stomach. So initially the fluid is just hyperechoic, and the gastric secretions or clear fluids, clear juices, they produce a hyperechoic appearance. But immediately after fluid intake, gas bubbles can be appreciated as small punctate, and they disappear rapidly with minutes of ingestion. This is called typically the starry night appearance. So when we take food, when we chew and we swallow, invariably the air is ingested with the food. So in the early stages of solid consumption, this air prevents a sonographic visualization of deeper structures and create a curtain-like image, which is called a frosted glass appearance. But in the later stages or after the initial stage of 1 to 2 hours of fluid intake, the air in the antrum becomes either absorbed or displaced, and solids appear hyperechoic with a heterogeneous consistency within a distended antrum. Milk curdles can have a typical biphasic hyperechoic and hypoechoic appearance. So to define or to answer a well-defined clinical question whether the stomach is empty or full, we should be first of all have an acceptable definition of full stomach. Now this definition, although this definition also controversial and open to interpretation, but the full stomach can be defined as any solid or thick particulate content or clear fluid than baseline gastric secretions of greater than 1.5 ml per kg actual body weight or approximately 100 to 130 ml. So how we interpret these findings or risk stratification, aspiration risk stratification. So first of all, we qualify. First of all, we do the qualification or the qualification of the gastric content. The qualitative exam, if you see the empty stomach, that means a grade 0 antrum, and that means the aspiration risk is low. I'll define this further. So when clear fluid is present, a volume assessment can discriminate between a low volume and with a fasting intake and a high volume suggestive of a non-fasting state. So the cross-sectional area of the antrum has a linear correlation with the gastric volume, and to measure the cross-sectional area of the gastric antrum on ultrasound machine, first of all we have identify the gastric antrum and have a still image. Then we use a caliper on ultrasound machine to measure including the full thickness of the gastric wall from serosa to serosa, and then use a predictive model to assess the gastric volume. So the cutoff values for empty stomach, any of the following: if there is no content visible in any patient position, that means this is grade 0 antrum. If the clear fluid in the right lateral decubitus but appears empty when supine, grade 1 antrum. And if there is a clear fluid with a cross-sectional area of less than 10 centimeter of square in the right lateral decubitus position, or a clear fluid with estimated gastric volume less than 1.5 ml per kg. The full stomach is any of the following if present: if thick fluid or solid content in any patient position, antrum distended with clear fluid evident in both supine and right lateral decubitus position, or a clear fluid with cross-sectional area of greater than 10 centimeter of square in the right lateral decubitus position for an average adult. So what these findings will help us? So comes to medical decision making. So your findings will help you decide. You may delay, you may cancel, you may proceed plus minus with the aspiration prophylaxis. You may insert a nasogastric tube pre-operatively or post-operatively, or use a laryngeal mask or endotracheal tube, or do standard intubation or a rapid sequence induction. So gastric ultrasound should be used as an adjunctive tool to increase the margin of safety when performing anesthetic interventions. It has a sensitivity of 1, it has a specificity of 0.9, it has a positive predictive value of 0.9, but it does have a negative predictive value as well. There are some limitations of gastric ultrasound, like gastric ultrasound findings may not be inaccurate in patients with previous gastric bypass surgery, or a gastric band in situ, or a previous fundoplication, or a large hiatal hernia. So what is the current evidence or the literature review about the gastric ultrasound to do the risk stratification? So there is a growing body of evidence that addition of point-of-care gastric ultrasound to a patient's history and physical exam, this can modify aspiration risk assessment and anesthetic management in a substantial proportion of cases when clinical data alone is uncertain. Now, when I search this topic and look at these studies, this is the amount of published data on the gastric ultrasound and the gastric emptying time. So you can see a number of published studies in every subset of population: reviews, adult qualitative content, volume, pediatrics, obstetrics, case report, intensive care, emergency medicine, diabetes, and education. So the studies are there already. I will like to quote two recent studies. One is the Anaesthesia journal, which is in 2023, which is preoperative gastric ultrasound in patients at risk of pulmonary aspiration. This is a prospective observational study. And overall, 2,003 patients are included in this study. And what is actually showing the numbers that there is a change in patient management based on the gastric ultrasound. They have a more liberal management in overall 303 patients, and there is a more conservative approach to intubation, like doing the rapid sequence or delay or cancel the case in 76 of the patients. And what they conclude in this study is that the preoperative gastric ultrasound helps to identify high and low risk situations in patient at risk of aspiration. This adds information to perioperative airway management and can lead to changes in patient care. Another review which is published in the European Journal of Anaesthesia and Intensive Care in 2023, this is a review and clinical guidance, and after selection and after doing a preliminary Medline and M-based search, the 5 studies they included in this review, they come out with this algorithm. I'm not going into the detail, but the conclusion of this European Journal of Intensive Care, Anesthesia and Intensive Care review says that the incidence of a full stomach at the time of induction of anesthesia for emergency surgery varied between 18 to 56%. Currently, there are no fasting guidelines, and the clinical judgment of an empty stomach is unreliable in the emergency surgery subgroup. And the gastric ultrasound is a valuable tool for evaluating gastric content, as most studies found no correlation between fasting times and the presence of a full or empty stomach. So gastric point of care ultrasound can be seen in 2 ways. One is the research entity and one is the clinical entity. So for research part, we have seen the many publications. These are some specific publications for the pediatric anesthesia, the utility of gastric ultrasound in the safe pediatric anesthesia practice. The clinical utility, the clinical entity of gastric ultrasound, how it is incorporated. So the anesthesiology group at the University of California first to report incorporation of gastric ultrasound to a residency curriculum in 2015. The ASA launched the first certificate of completion course point of care ultrasound directed towards the anesthesiologists in 2021. And the gastric ultrasound was selected along with cardiac and lung assessment as the first 3 organ system examinations to be incorporated. And perhaps the most important step is its incorporation into our clinical practice. So gastric point of care ultrasound to become an established diagnostic modality, its incorporation into the fasting guidelines in the 2022 European Society of Guidelines, which is published in European Journal of Anesthesia. And this guideline for fasting in children, this guideline specifically point out 3 important recommendations regarding the use of gastric ultrasound. So in conclusion, point of care gastric ultrasound is used as an aspiration risk assessment stratification tool. Its validity and reliability have been evaluated for a variety of patient population, is more useful to guide patient management when prandial status, when NPO status is uncertain or unknown. Now, whether it will lead to a reduction in episodes of clinically important aspiration, that question needs to be answered with large-scale studies, and it's still the literature is coming off these studies. Thank you very much.
Thank you, ma'am, and thank you, Dr. Faisal. May I request the speakers who have just delivered their talks to please come on the podium and take their chairs, and we open the session for question and answers.
Can I make a comment rather than a question? Whenever we discuss it with the surgeons, because pediatrics is not just, only the pediatric surgeon does not operate on a child. There are these orthopedic surgeons, different specialties. And what happens is, that if you tell them that please give 2 hours, you can give prior to the surgery, you can give clear liquids, they say they will not understand. The parents are not going to understand the difference between clear fluids. And so what I feel is that education of the parents is the most important step. One, because and secondly, the problems in our setup, as Farjad mentioned in his talk, that, you know, there's a lot of dehydration. I don't think we should be following the Western guidelines. We should develop our own guidelines, because the children really get dehydrated and they are so anxious and they are so stressed out. So I think parent education, maybe we should make brochures or whatever. But I think that's and educating our surgeons, not just the parents.
Anyone else from the audience to have a question? Yes, Dr. Shibli. Yeah, you want to add something?
Yes, thank you very much, ma'am. That's quite true. But it's what they have suggested. It is not just the parent education, but the staff as well. And because when the patient gets admitted, then the staff, and this, I'm talking about first world countries where they did an audit, they taught everybody how to improve. And 6 months later, they had the same results, if not worse. And they were extremely frustrated. And they had talked to the parents, and the parents were saying, we wanted to do it, but the staff did not allow us. So it's not just the parents, it's the staff education as well. So it's a team effort. Everybody needs to know this is what is happening. And we need to factor in the geographical and the seasonal variability as well in all of this.
And Dr. Shibli wanted to ask some question.
Thank you. Wonderful topic and wonderful talk. And Dr. Saida has said 50% of what I would have liked to say. Basically, Dr. Shahab mentioned about this contextualized guidelines. Why not? Yeah, PSA can do it. We follow ASA guidelines. Why not PSA guidelines? And because our context is totally different. Somehow in other countries, we are developing, like I work in Middle East, so they are contextualizing. But after contextualization, what they do, they make it a policy coming from the clinical guidelines committee, and we all have to follow that one for legal reasons, medical legal reasons. So sometimes we have to apply those even in pediatrics, and we feel sorry about it. But we have to make, I think, the contextualized one. And education is very important. I'm itching to tell you something very interesting, actually. I'm itching, really. I was working in a hospital here, and I had an elective list. And early morning, somebody said, there's an accident on a young guy. He was driving to work, and he broke his wrist. So they're coming. So I said, नाश्ता तो किया हुआ होगा इन्होंने, तो अब इनको थोड़ा सा delay होगा, लेकिन बुला लें. So they came, and a smart husband, wife, and I said, आपने नाश्ता तो किया होगा? तो उन्होंने कहा कि नहीं आज तो मैंने नाश्ता नहीं किया. तो मैंने कहा चलें, ये तो बड़ी अच्छी बात है, फिर आपको हम जल्दी कर लेंगे in between that. तो वो कह रहे नहीं, घर गए थे तो बेगम ने दूध में हल्दी मिला के और शहद मिला के उनको दे दिया था.
इससे हीलिंग अच्छी होती है.
मैंने उनसे कहा ये आपने ऐसा क्यों किया? तो उन्होंने कहा नहीं, दूध भी खालिस था, हल्दी भी घर में पिसती और सवाद से शहद आया था. तो मैंने कहा जब तक हम करेंगे तो हड्डी तो जुड़ जाएगी आपके नुस्खे से. तो इसका मतलब हम 4 घंटे वेट करके एक एक्सरे करा लेते हैं. तो एजुकेशन फॉर द लर्नेड वंस एंड एजुकेटेड वंस इज वेरी इंपॉर्टेंट एज वेल. सो I think education, and the contextualized guidelines through the PSA, through the experiences of seniors and juniors, and on all these instances we all contribute to. I think very important. Thank you, Shahab, for raising this one, and I think Dr. Shabir Jumani and others, they will take up on that one at the official level. Thank you, Farjad. Thank you, Faisal. Thank you. Well done. Thank you.
Thanks a lot.
मैं पर्सनली PSA से यही रिक्वेस्ट करूँगा कि इस सिलसिले में कोई टास्क फोर्स बना दें, and let's have the task force and with the help of the, we have so many tools now available. अब तो handheld devices आ गई अल्ट्रासाउंड की, तो अल्ट्रासाउंड हम सब बच्चों को सिखा दें, and then we get the content of the stomachs बच्चों में, बड़ों में, and different populations बना के, so we can make our guidelines. It's not too difficult at all. It's just a matter of doing it. और उसमें determination की ज़रूरत है और अब तो हमारे पास इतनी younger force है माशाल्लाह और they are much more educated and much more energetic than we were. So I'm sure they can do much better time than, much better things to the specialty than we could. Thank you.
Dr. Fawzia, you want to say something?
Just taking this forward, it's a good suggestion that PSA should make guidelines. But then for guidelines, you need data. We don't have any local data at all. So I would request the departments, I mean, there are so many residents who do their dissertations. Why not take this up and have some local data? And of course, education is important.
So just one question for the whole group. So we did an audit at, so can
Please speak loud.
So we did an audit in our setup. We do pediatric lists on a daily basis. We've got 15, 16 pediatric patients on a single day. And what we found was that the NPO timings on those patients that were at the end of the list were significantly higher. So the comment that General Chahab made at the start, वो रात 10 बजे जो है के बाद कुछ खाना पीना नहीं है. So when we changed that to कि सुबह 3 बजे के बाद कुछ खाना पीना नहीं है. So that didn't improve our NPO timings as well, and the patients that were at the end of the list, they were significantly NPO for large period of time. So my question is, do the guidelines kind of address the issue of list management of pediatric patients, and that would, I think, would be the way forward for if we make any guidelines. The other sort of question is that the UK and Irish societies have given the guidelines for minimizing the NPO for pediatric patients to 1 hour now for clear fluids. But we see that there is still a lot of resistance from the surgical sort of societies and the other societies as well in terms of implementing these guidelines. I'm not sure if the reason is the lack of scientific evidence or just using traditional methods. Thank you.
I have a question as well.
Okay.
You want to talk? Yeah, please.
Answer the
Go
question?
ahead. Sorry,
right. So thank you, Saad, very much for the question. First, regarding an audit, what Dr. Fawzia said, I think it's a great idea that we should have local data first. But what I would suggest is, with the local data, we should do it for at least a year so that we can see the seasonal variability. And it should be not a single center, but multi-center as well. So that's the first one. Second, regarding the prolonged fasting, it's well documented that the longest fasting time is usually for the first child on the list and those at the very end. What they do suggest is that if you keep the first child on the list separately and depending on the number of theaters you're running, and the second patient should be given a small drink of carbohydrate fluid early in the morning. That will help things out. And yes, they do recommend at least 2 hours for clear fluids, but they do say carbohydrate loaded fluids. It does help. What was the second question? This was it. Is it? Does that cover both things? Sir.
Yeah, luckily you have mentioned half part of it, what I was about to ask. What happened actually in the practical life, the patients are wheeled in or brought next to the theater in the waiting area, and the list goes on from morning 8 o'clock and finishes at 12, where we take the last patient. Suppose if it's in a civil hospital, usually it is up to 2, or in the different hospital, I don't know. But the status of the fasting of the different patients are different when they are actually brought to the table. So at one end, we have to do a very legitimate fasting, and at the same time, we want to avoid the prolonged fasting. So that is the, question arises, who will take care of that particular period when the patient is not in the ward, not with the mother, or they are just around the theater. So this is something to think about it and question.
So I remember Saad's second answer of whose responsibility or what the problem arises. I think Pakistan में खलाई मखलूक का बहुत मसला है, interference बहुत होती है खलाई मखलूक की. तो यहाँ पे भी ये खलाई मखलूक का ही मसला है. So I think education is very important for everyone involved in the perioperative care. जहाँ तक डॉक्टर जाहिद की बात है कि what happens in the interim, so we can't factor in everything. Who is responsible? All of us are. So it's a team effort. You can't say कि ये resident है या anesthesia team है, इनकी ही जिम्मेदारी है या pre-op clinic वालों की जिम्मेदारी है या इनकी जिम्मेदारी है. All of us as a team, if you're anesthetizing the patient, even the surgeons, whichever specialty, we have to make a document for that specialty, for that purpose, and we have to run it accordingly. And of course, there are going to be hitches in between, but we have to take the first step and then see how it evolves.
Dr. Shahida Khwaja, please.
I would like the suggestion from my senior and expert colleagues about the cerebral hypoxia patients who come for different congenital anomalies surgeries. They start screaming, they are hungry with this NPO protocol. So what would you all suggest to keep these patients calm and quiet? Supposing this patient has got congenital hip joint dislocation or for some kind of soft tissue injury, because this is the problem that I face most of the time for these children.
So, ma'am, what they have, that is why they suggested individualizing the care for a special subgroup. Again, these are all guidelines. We can't apply them to all patients. So, for specific subgroup of patients, we assess things and we make a guideline for them. That is the only way it will work. Second, they are a challenging group of patients. So, unless they have a swallowing problem, because again, they have mentioned that they may have a reflux problem. They are hungry, they are thirsty, but most of the times it's because के रात को खाना खिला दिया, पिला दिया शाम के 6-7 बजे और उसके बाद से कुछ नहीं दिया. And they're coming into theater at 8 o'clock in the morning. So that's 12 plus hours of fasting, and we've all seen it. So even a small sip of water, carbohydrate loaded water in the morning will calm them down. What does work sometimes is a 25% dextrose ampule, just wetting their lips, they will relax significantly down. If that works, giving them a bit of water, and in the summertime, if possible, getting an IV access and hydrating them does work. But again, such patients will remain a challenge. They will.
Okay, we have maybe another question, but we cannot take it because we are already, 7 to 8 minutes over. So I would like our chairpersons to please come and distribute the certificate to the speakers. Dr. Fawzia, please give this certificate to Dr. Shahab Naqvi. Please. Dr. Shahida Khwaja, please give the certificate to Dr. Farjat Sultan. And next, Dr. Fawzia, please give the certificate to Faisal Shamim. May I request Dr. Akhtar Aziz Khan to please come on the dais and give these certificates to our respectable chairpersons.
Yeah.
Dr. Fawzia Aziz Khan. Dr. Shahida Khwaja. And it is for me, myself. एक मैं announcement कर दूं एक जी जी एक announcement.
Before the final announcement, I, as patron of PSA Lahore, congratulate the PSA of Karachi for holding such a successful event, full of knowledge which is bubbling out of our youngsters and obviously of the seniors as well. Many, many congratulations on everything. Thank you so much for making us part of it. Thank you.
As far as the task force is concerned, PSA is ready to form a task force consisting of different heads of the departments of anesthesiology, and they can collect the data and, then we can make the guidelines as far as this problem is concerned.
One more, you can see the QR code. So scan the code and the form will appear, and fill up the form and send it back. We will give you the e-certificate. The organizers of the conference will give you participation of e-certificate. Thank you. With this, session is over, and thank you so much.